Hi, y'all. I'm Lisa Ehrlich. I'm an internist in Houston, Texas, and I have a little rundown. I'm going to try to use these slides to keep myself on track so I can work through all of this stuff. I'm an internal medicine doctor. Like I said, I work in the medical center in Houston. I got my MD degree at UTMB in 1993. I did my residency at University of Michigan and finished that in 1996. Then I stayed on faculty there at University of Michigan in Ann Arbor doing a chief year, and that's what I always thought I wanted to do with my life, academic medicine. But I didn't like it so much, so I moved to Houston and joined a large multi-specialty group in private practice. I worked there from 1997 to 2002. I learned a whole lot of stuff. Built my practice, and then in 2002 I went out on my own, and I'm currently part of a 4-physician internal medicine group, single specialty, right there in the medical center. So my current practice overview, and actually before I do that, if I could have the first slide. This is my current practice overview. I just wanted to write it down so I didn't forget anything. We are 4 full-time physicians, 3 female internists, and we have our 1 token male. He really, my husband thinks he's got to be crazy, but he has a good time with us. We're all single specialty, internal medicine, like I said, Texas Medical Center. Our patient demographic includes Houston. Since we're med center based, we do a lot of central Houston stuff. If you know Houston, Memorial, Bel Air, River Oaks, West University make up a big part of our practice, but we also serve a wider southeast Texas and Louisiana. We have a lot of patients that drive in from Brownsville and other places. We accept many PPOs and Medicare. I said non-assignment, but actually that's non-participating. We do not accept Medicaid. In fact, all of our Medicaid patients that we see in our practice are charity care, and that's how we usually don't charge them anything. And we don't do any HMOs. We try not to do HMOs, and we don't do any Medicare HMO. Here's my next. I don't know if y'all can read that. When small practice physicians start talking about implementing an electronic health record or implementing quality health measures, I think this is how we feel. I can't even read that. I need to get my glasses on. But anyway, basically she doesn't know whether to stick a hot poker in her ear or cook dinner for a bunch of ungrateful brats. So I've gone through this. We just implemented electronic health record 1 year ago, a little more than 1 year ago. The only reason my staff didn't fling themselves out of the windows, I always say, is because those windows didn't open. But they're all still here. Every last one of my staff members. All of our nurses have gone through the training, and I have to say, on the other side of it, we're running like a top. It's actually, things are much better, and it wasn't as painful as that. If I can go to the next slide, please. So one of the questions is about quality implementation, what we're talking about here today, quality. How to implement that is probably one of the first questions. You all have already talked about PQRI and PQRS, meaningful use, this morning, so I'm not going to go over all of that. But we had been doing this even before EMR through the pull downs and putting in the G codes and that kind of stuff. I have to say my office hasn't gotten a penny on it, but there are some physicians who have. We also did electronic prescribing a long time before we did EHR. With quality implementation, these things are good to get your feet started with, and we have to do PQRS. That's coming down the pike. You just can't get away from it. It's going to be very hard to do PQRS without an electronic health record. One other way that we have been implementing quality into our practice is through St. Luke's IPA, there's a clinical integration pilot. And this is actually kind of bare bones. They take billing data and set benchmarks, and are we doing our A1Cs, and are our diabetics having their ophthalmologic care, that kind of stuff, very basic. But it's allowed us to start getting our feet wet with that as well. Electronic health record, absolutely necessary. I think you guys have probably already heard some about that. And then Bridges to Excellence is another way that this is actually just very recently my office is working on. And are y'all familiar about Bridges to Excellence? Yeah, it's it came out of the Leapfrog sort of employers' ideas about what they want for their employees, quality care. But we have been actually working on this Bridges to Excellent track with Joe and with the TMA, and it looks like we're probably going to see some good effects of that. So I'll tell you a little bit more about that later. I'll go to the next slide. Basically, I just repeated all these, but monetary rewards. PQRI, PQRS, haven't seen any yet. We're working as well with the Regional Extension Center to see if we can shore that up. We've submitted everything, we just haven't seen any money yet. Electronic prescribing, kind of goes into the same thing, and then Bridges to Excellence, I'm going to talk about one second. Bridges to Excellence basically has a system by which the physicians can get certified as a Bridges to Excellence physician. If that happens, the payer, in this case Blue Cross Blue Shield, will pay on your number of patients that meet that criteria per year, per patient year. So for Blue Cross Blue Shield, if you're diabetic, certified Bridges to Excellence, and you have 28 diabetics that are Blue Cross Blue Shield, they'll pay you $100 per patient, which translates to that much money in a year, $2,800 a year, for instance. We're hoping that this will expand further to other payers and that they'll be streamlined and we'll be able to do the same sorts of things. It does require some work from staff and other things, but Aetna and Cigna, I think, are also looking at this, so if we can extend that to more of our payers, that'd be really great. And then clinical integration. For a smaller practice, and you'll hear about some of the more financially integrated, bigger practices. For smaller practices, it's nice if we can try to clinically integrate ourselves so that we can set measures, set benchmark, follow ourselves along, and perhaps the payers and the employers and the patients will appreciate that we are integrating care with each other for quality. And then my last slide. I'm moving along pretty fast. Sometimes I talk too fast, sorry about that. So actual quality improvement, better patient care and outcomes is really what we want at the end of the day. We want to be paid for our work for doing that, for having better patient quality and outcomes. PQRS, meaningful use, this is coming. There are some onerous things, but there are some great things for patients, as we've already talked about. Electronic prescribing is clearly valuable in quality. It's medication reconciliation and interactions and making sure your patients are on the right thing, and electronic prescribing is very helpful also with formulary. And then clinical integration again. This kind of goes into integrating and having a more streamlined flow of information as it comes down the pike from physician to patient to the next physician to the next health system to their CT scans and their radiologic laboratory, all of those things being in the same place or being available access to for people who are trying to care for these patients. And then the last thing, again, Bridges to Excellence. I think that this incentivizes physicians to go spend some money and some time and devote some staff time And there's actually probably a good quality outcome. Just as Dr. Updike was saying, we can see our patients getting better care if we're benchmarking and we can see who's had their Pneumovax and who hasn't. If we can see if their A1Cs are where they should be, this is a way to do it. And electronic health record, there's no doubt about it. Way better to see that stuff than paper. It will be the wave of the future and the wave of now, really. It's expensive, it's hard, but it's really necessary for quality of care. You guys have any questions for me? No? You know what? I had one more slide just to remind myself. It's just a pie chart, and it doesn't have anything on it. That doesn't mean anything, that pie chart, just to remind myself. We are moving forward into a shrinking pie. And so everybody's trying to get a part of the pie, but the pie's not growing. This is where we're probably going to be butting heads against hospitals and insurance companies and payers and you name it. So we need to keep our eye on this pie chart and realize that it's smaller, and then we need to streamline and figure out efficiencies that improve quality of care for our patients and still allow us to see our patients in a reasonable manner. That's all. Thanks.